Here we go. Disclosure-wise, I am a consultant to the laser companies I'm going to talk about, but I don't get paid, and they really don't like to hear me complain about their stuff all the time. But nonetheless, I have been a consultant plus some gene therapy companies very recently. This is the part where I usually thank the organizers, but in this particular case, I need to thank the gods of epilepsy. This is my view going to work for about 9 months. 50-foot Dave looking down at me. So this is an offer I could not refuse. So objective-wise, we're going to go over hypothalamic hamartomas, what they are, and the surgical techniques in the ablative world. So HH is an uncommon condition. It's famous for a refractory epilepsy of gelastic origin. It's famous for an epileptic encephalopathy, and they're notoriously resistant to a medical management. It's been frequently delayed. It's usually a giggly kid that nobody really pays attention to until a secondary seizure will occur. As I mentioned, the epileptic encephalopathy was described a long time ago. And the seizures, there are some advantages to medical management in the secondary epilepsy world, but not in the hamartoma. It's been classified in a number of ways, and as I mentioned this morning, the classification schemes are very much depend on what technique you're going to use. So an endoscopic disconnection in the Dell world was broken into 4. In the stereotactic radiosurgery world, it was broken down into 6. And really, we kind of use the stereotactic epilepsy, or the stereotactic radiosurgery classification that Jean Regis did in about 2003, I think. So we're trying for a cure, which is possible on the small ones, but not necessarily on the large ones. Palliative, or we're trying to palliate the epilepsy in the encephalopathic kids. Sometimes we can reduce the rage attacks, but we're looking into when this is possible and when it is not. It's usually having to do with whether the epilepsy has been improved upon. And of course, complication avoidance, because this is a lesion very deep in the brain where surgical complications have been very common in the open world. So I'm going to go over the ablative approaches, which is the radiosurgery I mentioned, and radiofrequency, which is an older way of doing it, and I'm going to mention focused ultrasound, but I'm really going to go over laser ablation because that's what we do most commonly. So in radiosurgery, the important factor here is this is a very large series done in France, and they have 0 neurologic or endocrine complications, which no one can say in the other techniques that have been applied here. Problem is, it's only really effective on the small ones or on the low-frequency seizures, and they only cure about 37% of these patients. So if you're looking for safety, this is the way to go. However, and another aspect of laser surgery is it's not worldwide, so most of the folks that have been developing ablative HH surgery over the years used radiofrequency. Old school, put an ablator in. We did it for movement disorders since the 40s. Problem is it only makes about a 2 to 3 millimeter ablation at a time, so the volumes that you can ablate at any given time are disproportionate to your mass. And so, and the other aspect to it is it's done blindly. You know, you put in the probe and you go 73 degrees for so many seconds and you hear a pop and you move on. That is ablative surgery prior to laser ablation. And when you do that blindly, you really don't know where the heat goes, and it's a pretty busy area, so the complications of this technique have been fairly high, but they have been effective. Focused ultrasound is a great new idea here. Miami Children's is starting it as a 0 corridor morbidity because you're just putting the ultrasound waves through. So it may improve the safety profile, and it may have a mechanism that's not just thermal but non-thermal as well. But we don't really know. It may even bring in the prospect of an outpatient approach here. But we don't know a lot of things about focused ultrasound in kids. We don't know what the immature cranium is going to do. We don't know what the dosing is at the fluid interfaces because the focused ultrasound was designed for the isothermic world of the thalamus. So we're going to run into a lot of questions here. It may be accurate, it may be not, we don't know. There's going to be a mismatch between your ablation volume and your lesion, so you're going to have to do it a bunch of times. And so there's going to have to be some refinement of a disconnection strategy. In this particular case, what was published, the only one published, is from the Japanese group, And they somehow found a way of doing a DTI that showed the connectivity of this HH. And we have tried this 100 times and can't get any data. Nonetheless, they did it. They found a tract. They ablated it with a focused ultrasound system, and it worked. So it's a small lesion. You see that tiny little dot, yet it disconnected it. I'm not sure about that whole disconnection strategy, but it gives you an idea. If you ever had to go to a volumetric disconnection with HIFU, that is what you're up against. So laser ablation, why? Because it's a deep lesion. It's known to be epileptogenic. It's associated with the encephalopathy that we talked about. It's a minimally invasive approach that avoids a lot of the corridor-related morbidity. That's a phrase that I use for all the destruction that occurs when we have to do an orbital zygomatic or some huge cranie on a baby and lift up their brain. We don't have to do any of that if we just put a 1 millimeter probe right into it. It's a minimal hospital stay, and the thermal treatment is an immediate effect as opposed to radiosurgery, which can take up to 3 years. It's MR compatible, so you can see what you're doing. It allows you to dose by thermography. Now, there's a lot of papers that go out and talk about radio frequency ablation too that's MR guided. It really isn't. It's MR planned. This is actually MR guided. Most technically, it's MR thermogram guided. In other words, you're using a thermogram to show you the heat, to dose your lesion over your target. And that orange thing there is called an irreversible damage map. That's the area that's been estimated to be ablated. And in the comparison I did for the radio frequency in the bottom there. So our strategy generally surgically is try to disconnect first. It tends to be connected to the mammillary bodies, tends to be connected at the hypothalamic border. You want to do complete ablation last because you can run into some complications. We stage it, and we looked at our data and looked at how much we have to get in a first session to get the patients in the good outcome category, and it's about 60% of the lesion. So that's what our target is. We published the first ablation paper for epilepsy in general was 2 HHs amongst the 5, and then we expanded our series of the first 71, and we had some pretty impressive, actually it seemed almost too impressive outcomes. On 93% were seizure-free at a year. It was kind of a big number. Over time, it's more of a sober 84, but generally we're in a very high area of efficacy at 1 year, and that's the target seizures at 1 year. But about a quarter of them needed more than 1 session to achieve that. And that's gotten a little bit more common as the series has increased. Thermal ablation is just finding any way that you can heat that area of the brain to destroy it up to 43 degrees. 260 is a time-dependent one. That's what that Arrhenius equation shows you. After 60, it's instantly ablated, and as opposed to RF, where you're trying to form gas, you want to stay away from gas, so you stay below 100. And you use MR thermography. I don't understand the physics of it, but it's a proton shift that shows you where the change in heat is occurring at the target. It's not basic temperature, it's the change in temperature. So that is a bit of a problem because that baseline can shift, and I'll mention how I get around that. You can put in the fiber any way you feel comfortable with, any stereotactic system your surgeon is happy with. I'm wedded to rigid stereotaxy, and the robotics have been very big in my practice. I also use the ClearPoint system. There's 3 laser companies I'm going to talk about. One recently came on the market, but the 2 that dominated the market for many years was the Visualize system by Medtronic and the NeuroBlade by Monteris. There's a couple of important feature differences. One saline cooled, one CO2 cooled. Sizes are different. The Monteris tends to be a bigger probe, and the laser that they use is slightly different. Whether that really matters or not in HH, I'm not quite sure. In cortical scenarios, it may be a longer ablation time. Very new, cleared by the FDA, is a ClearPoint NeuroPrism. It has 3 separate diffuser tips, It is similar. It doesn't have a cooled system, though, and I have not used this myself. Here's just some slides I got from ClearPoint Neuro to demonstrate it. It looks very similar to the ablation volumes we get with the Monteris or with the Visualase, but the system here is a little bit different in that the safety margins are not points, in that they're fields. And I think that's pretty cool, because I've been complaining to the Visualase folks that they don't give me enough safety points. I want to flank everything I don't want to destroy. They give us a field now, so this may be a huge safety advantage, but we'll find out in the next 5 years. So this is what we actually see during an ablation. We have the anatomic structure superimposed on the thermogram, and we see the irreversible damage map covering our lesion, and then we know we've dosed enough and we can stop. We don't have to just go by some formulaic blind thing. And this is what the images look like afterwards. Here's the flare with the probe in. There's the irreversible damage map in the middle, and there's the enhancing HH. Our considerations in planning HH surgery and what patients we encounter, we want to consider the seizure burden, the age, the trajectory of the encephalopathy. We don't want them to worsen. We want to see what the intellectual ability is, or the potential. Skull maturity may or may not matter. I don't let the skull maturity delay me. And the operative history, of course, whether there's residual, whether there's surgical traps. So patient selection in most HH patients for laser ablation, as far as I'm concerned, if they're young, high seizure burden, they're encephalopathic, they're good candidates for the laser ablation. However, pause should be given to the older children, young adults, smaller lesion where complications may occur, normal intelligence where you can only fail, lower seizure burden. Maybe radiosurgery is the best fit there. And you just pick the best tool that you have available. Complication-wise, we've had 2 bad memory problems. We had a transient DI. We had no permanent hypothalamic obesity induced, but we had 7 transient sodium disturbances. Tends to be in the giant hamartoma population that we had to bring back for some minor sort of resuscitation. We had 3 cranial nerve palsies, and this is mainly in the giant category where the lesion is so complex you can't see where the cranial nerves are. Recurrence-wise, our general view is if it's a gelastic seizure, we still tend to want to focus on the hamartoma. If there's no hamartoma at all, we go to the stereo EEG. The non-gelastics, we just go to the stereo G right away. But our exact flow of recurrence does vary, I must say. Reoperation is very easy with this too. If you have an open craniotomy that failed, reoperating with a single probe is very easy here. So some evidence of variable epileptogenicity and connectivity in these lesions because they're very large. Here's a HH that we ablated, and they still seized a great deal. Here's another example of a very large lesion where we kept doing ablation sessions, and the seizures kept coming back, and I had 2 choices as to whether I take the lateral one or the medial one. And there has been some work with resting state functional MRI, something called Searchlight, where you can search around with a cursor and see which part of the hamartoma is most connected to the brain. And we used that on this particular case done by Verena Wolf, and we were able to target the one side, and the seizures finally stopped. So there is some variability here. There is some residual on the other side, yet that's not seizing. We always use postoperative steroids because the edema is tremendous, and you really don't want a bunch of edema through the hypothalamus in an acute way. I've used a protocol here that's kept people going home on post-op day 2. And got to always worry about heat sinks and how they are affecting where the heat is going. Here's another issue. We do some ablation sessions and change the anatomy. We actually create some of the heat sinks. Here's a little bridge of residual hamartoma that I basically created, and now thermally that's going to be very challenging to get after. Here's another example of a patient came to me after a failed ablation elsewhere, and they basically made a whole isthmus that's surrounded by CSF. You can even see the flow voids near the tip. So that's going to cool off drastically, and you have to strategically put your tip right on that heat sink. What we've learned over time, and this is the ablation of that kid, and finally stop seizing. Naturally, a lot of these type 2s and type 3s will have CSF on 3 sides. So you have to keep that in mind. This is one where we tried to get to the isthmus of the lesion. I went a little too medial, and I really couldn't get it all on the enhanced, but she stopped seizing anyway, so I'm waiting for the other shoe to drop here. But sometimes when you have to go that laterally into the heat sink, you can actually get to the other side. So it's a technical nuance of some of the shapes of these, which if we had high-frequency ultrasound, we could just select it. I wouldn't have to worry about those things. Sometimes the lesion's so small you can't get a differential between your heat source and keeping the surrounding brain cool enough. It's about 1 to 2, maybe 3 millimeters of lesion. Thermal ablation is never going to help. You have to find some other way of treating that patient, and radiosurgery would be the first thing to do. Giant hamartomas are a special case. There's a literature that says giant hamartomas are the ones you should openly operate. I disagree with that wholeheartedly because I think we can still get the job done. It just takes a lot of lasers. They have a higher morbidity, but they have a higher pre-op morbidity too. I mentioned the salt wasting syndrome tends to be in infants with large masses that get ablated at one session. And here's an example of that. I think it was a 5-laser ablation. And here's what it looked like afterwards. A couple of movies showing the ablated volume of T1 infused here and the T2 on the right, showing you can get the vast majority of it, and this kid stopped seizing. You can get cranial nerve palsies here because it drops into the cistern where you really can't see the cranial nerves very easily. We've had 3 of them, most importantly a Delilon type 4, where the lesion is outside the junction of where the fornix hits the mammillary body. Third nerve can live there. It's not always a permanent problem, but it's something to very much worry about. And we're trying to figure out a better way of seeing that up front. I'll race through these examples as just examples of a kid with lots of seizures, over 100 a day. We did three. I already showed you this post-op one. This is kind of the scenario and the sequence of the ablation sessions. This is intellectually normal 10-year-old daily seizures. There's options here, but they are daily, and there were grades that were dropping, so she opted for a laser ablation, and luckily it went quite well. You can see the ablation volume down on the bottom right is pretty much covering the lesion. This is her 3 months later, and there's no residual, maybe a tiny little bit of scar above. She's still seizure-free. But radiosurgery could have been applied there and simply waited. This is a residual that was sent to me after they refused another open operation, and you could go either way on this one too, because there's already injury from a previous operation. When that happens, I tend to be cautious, but laser fit well here too. Another volumetric mass here that we went after, 6 seizures a day, more than daily seizures. I think you can't wait for radiosurgery. And this is a residual where small lesion occurred, small brief seizures, not interrupting this 10-year-old's life. We opted for radiosurgery here, sent her to France, and she's fine. So in conclusion, the HH surgery should be tailored to the presentation of the patient. Lit's well suited for this because it minimizes the corridor-related surgery, or the corridor-related morbidity, and we have to do a judicious use of all the safety features your device can give you to protect the memory circuits. We've lowered that in our series. We'd like to think about combinational treatment strategy. Don't just stick to one gun. And hopefully in the future we'll have maybe focused ultrasound or neuroaugmentation strategies or even pharmacologic approaches directly into the ventricle that will prevent me from having to risk the circuitry. And with that, I thank you.